introduction. It's an absolute honor and privilege for me to speak here today, and I want to thank the organizers of this conference for allowing me for this World Congress, for this opportunity. I have no formal training as an intensivist. I have a diploma in Anaesthetics that I attained in the Fiji School of Medicine, during which I spent some time in the ICU in Fiji. But I've worked most of the last 13 years in Samoa, initially in Anaesthetics and for the last 4 years in intensive care. The only other time I've spent away was during a 2-year attachment in New Zealand, during which I was a registrar at the Melbourne Critical Care Complex. I've not published any papers or done much in the way of research, very similarly in the developing world. But all I've ever had was a desire to improve the healthcare in my country, that the least of my people would receive the best possible quality of care, just like everyone else. I know there are many in the audience who may not have heard of Samoa at all, so please allow me to share a little bit about my home. Samoa is this tiny speck of a country in the middle of the Pacific Ocean. It's so small that on the world map you need a big arrow to see it. With a landmass of 2,800 square kilometers, it's only a quarter of Melbourne City, and with an even smaller and very young population of 195,000, where 50% of them are less than 19 years old. It's a small country, but it's a country with generally a lot of heart. You can say we compensate for our tininess with passion. It's known as a tropical paradise, with all the pleasures of nature that it brings, and its people are very proud of their cultural heritage and are deeply rooted in its traditional beliefs and values. We call it the Fa Samoa. And this tends to spill over to the way health is perceived, and in my belief, greatly affects their health-seeking behavior. Like many Pacific Island countries, Samoa is fighting an uphill battle with non-communicable diseases. It's now the 3rd highest mean body mass index in the world, with 85% of its population, adult population, being obese or overweight. Type 2 diabetes, hypertension, and ischemic heart diseases are the highest causes of premature deaths among adults. For children, possibly related to the rise in NCDs, neonatal deaths are predominantly related to prematurity and congenital anomalies that accounts for about 45% of the under 5-year mortality rate. But when you remove that subgroup of patients, communicable diseases are still the main causes of significant morbidity and mortality. Perhaps similar to many low-middle income countries, in Samoa, going to the hospital is not always the first option when you're unwell. There's a general belief in the community that when someone is sick, they either have a Samoan illness that can only be cured by traditional medicine, or they might have a palangi or Western illness that may need Western medicine. There's generally a lot of distrust among the public of the general healthcare system, and many only present to hospital once they have exhausted all other options. And the decision is often dictated by the collective family or family chief, rather than the parents or even the adult patient alone. This also extends to decisions for critical management, including life-saving surgery, renal replacement therapy, even ventilation and central access. The family has to agree or nothing can be done. And there's no policy or enforced law to support the clinicians if they want to deliver this without the family's consent, and even if it's in the patient's best interest. So we often have to convince the family before we can initiate treatment. So the most vulnerable population in Samoa are the children. And in my country, it's not uncommon to have children presenting in critical condition, in extremis, or even perimortem. There's only one tertiary hospital on the main island, Tupua Meaole Hospital, with 300 beds. It receives referrals from smaller subdivisional hospital and nurse-manned health centers along the coast. There's one laboratory, one radiology department, and resources are very limited and many tests are not available. Sometimes the ones that are become unavailable due to reagent supply shortages or machine malfunction. The tertiary hospital has all the expected specialties and services provided by less than 50 registered senior and junior doctors and about 200 nurses. In the past, the high dependency unit has served for more than 20 years as an open unit that served all departments on a first come, first served basis for all patients that needed ventilation. And it was settled in a very fragmented manner, in that the anaesthetic department looked after the ventilator and helped put in the lines, the surgeons would do the operation, look after the surgical needs, and the medical or pediatric team would look after the medical problems. It was a system that was very fragmented in its provision of patient care, and often depended on general trained nurses in the ward to coordinate the patient's care. Death was generally an accepted and sometimes an expected outcome when someone got severely unwell and needed admission into hospital. 2 consecutive audits in 2011 and 2012 showed high mortality rates of 56% and 82%, respectively, for the ventilated patients in this cohort. But that was until 2015. In 2015, we were very fortunate to have Dr. David Gallo with us for a year, during which he started and developed an intensive care service in Samoa. With the clinical leadership of the hospital and approval and support of the hospital management and board, we started a service with the goal of identifying and treating early severe acute reversible disease with a focus on children and young adults. To start it off, we had a 6-bed ICU with the responsible medical team consisting of 1 consultant, Dr. Biala, and 2 local registrars, one with an interest in pediatrics and one with background of anaesthetics, me, and 12 full-time nurses. Equipment was purchased by the government and through donations from the Strawbridge Fund, and some of it also was donated by Dr. Gala. And we functioned as a closed unit and served a wide variety of cases, from neonates who were just hours old to children, adults, elderly patients. As long as they had a potentially reversible disease process, we were willing to try within limitations, and they were prioritized and admitted in the ICU. In our collective experience under Dr. Gala's leadership, our intensive care service was developed despite many limitations by doing a few key things. Firstly, engaging and investing in our nursing leadership. The first thing we needed to change was the mindset that ICU was like any other ward, and we had to start from within our own. In order to do that, we needed our nurses to see and appreciate the difference, and we needed them to drive the change that we needed to practice. Through partnership with Counties Manukau, DHB, and Middlemore Critical Care Complex, we were not only able to bring nurses from Middlemore ICU for periods of time throughout the year to teach our nurses what intensive care nursing actually was like, we were also able to send a couple of local nurses over to their ICU to see a different setting. And we worked in partnership together with our nurses with a common goal to improve outcomes for patients in our care. We worked together, fought our battles together through both medical and nursing lines of authority. And as a team, we agreed upon systems and protocols that we then stewarded and enforced by our own staff and adapted to our local setting so that it was practical and applicable. One of these systems was using one sheet to record all the vital signs, a 24-hour chart, rather than 5 different sheets that we had in the old system. Another priority was to train and retain local champions. In the beginning, Dr. Anaesthetics and I were the only doctors willing to join the intensive care service, having had some experience in it, albeit minimal. Additionally, as house officers were allowed to rotate into the ICU, it became an opportunity to upskill them in critical care management, regardless of whether they were going to stay in ICU. Moreover, we organized many short-term on-site training, like basic, PEDS basic, pre-hospital and hospital MIMS, and included not just the ICU workforce, but the whole hospital for both doctors and nurses. And as the benefits of the service became more evident, more junior doctors and interns became interested and wanted to join ICU, but not all of them were allowed by management to stay, despite our requests. The nurses with interest and capability to learn were encouraged to stay and retained in ICU. Previously, nurses were rotated around all the wards, and therefore there was a lot of loss of trained capacity. We created a support network and fostered a culture of support among local colleagues across the hospital. Because we were attending and offloading the wards and teams of critically unwell patients across all the departments, the service gained recognition and appreciation from other services and colleagues. We also had another key component to our success. Dr. Geller created an immense Viber and email network of intensivists in New Zealand and Australia that we could reach out to for advice, similarly to what was done in Mauritius. We sent cases on these forums and got immediate practical advice on patient management, and learned through these discussions the rationale and justification for the management choices. I've always been so thankful, especially for the pediatric cases. When in desperation, we would often call Dr. Miles and Dr. Perlini, and they always responded, "Oh, Starship, I see you," no matter what time. Through this network, we were able to accelerate learning from afar. But we also used it as a safety measure to check and ensure we were practicing safely and kept accountable with our management. In addition, several intensivists like Dr. Charlie Cork, Tony Williams, Louise Trent, Kirsten Bond, Chris Pointer, Cynthia Burrow, Pia Lawson-Smith, and advanced trainees Gerard Moynihan, Kathleen Thomas, Subi, and Andasiu were also able to visit during their sabbatical, and conducted on-site teaching and helped relieve a second call roster. Lastly, for those of us who choose to live and work in Samoa, there are only two things we hope for: training accreditation to be recognized as a specialist for both doctors and nurses, even if it meant we could only practice in our country. Especially since we were already working in the capacity. And secondly, we needed financial remuneration for the work we were doing, for most of us had families and loans to pay. So by 2016, Dr. Geller, even though he had returned, continued to support us and formulated a 3-year master's program in ICU that was approved and accepted by our local university to confer, and was approved by the government to sponsor. Unfortunately, due to some political and staff shortage issues, the program never went ahead. In 2018, we gained the interest of the College of Intensive Care. Thank you. And after evaluation by Dr. Cork as the CECU president, was recommended for and supported for an in-country postgraduate diploma program to be done in-country, with a tentative plan to start in 2020, but it required the government commitment before starting and was in the process of this discussion. Needless to say, working in intensive care in a resource-limited setting had very many challenges. Working in isolation, it's very easy to become complacent, with no one keeping you accountable. Or justify and explain your decisions to. Because of the nature of intensive care, there aren't many people you can ask advice from in my setting. So the Viber network and email discussions with the overseas colleagues was a greatest saving grace for me. But perhaps the biggest challenge to me was the human resource constraint. Having limited manpower in a system that didn't offer much support for intensive care services development and workforce itself meant that you wore multiple hats and fought multiple battles. It felt like a constant, never-ending war. As a head of unit, you fought for equipment, you fought for staff, you fought for medications, like adrenaline and noradrenaline that were life-saving, but managers couldn't see. As lead clinician, you were the sole responsible senior, conducting the ward rounds, being on call every day. As lead clinical educator, responsible for supervising your registrars, house officers that rotated through, coordinating and doing teaching, and ensuring they had a training program, regardless of whether it was accredited. Coordinated short courses that would benefit the whole hospital, because it meant that critical patients were recognized early and treated where they were at. Being a spare person for the roster when someone was on leave. Being the mediator for disagreements within the unit. Encouraging your staff and advocating for your patients. Making sure that everyone was coping in a stressful environment with debriefs to keep the team strong. But all of it came with a cost and made it near impossible to disconnect. For the last 3 years, I've been first and second call, even when I'm on holiday, overseas, or on maternity leave. I was constantly answering phones, giving advice, directing management from afar. And it meant that you can never switch off, and the low-grade chronic fatigue and lack of sleep slowly grinds at you day by day. It meant long hours for everyone, especially when you're at full capacity. The nurses had to do extra shifts, sometimes nurse 2 ventilated patients at a time, and it meant more mistakes out of tiredness and exhaustion, and I was no exception. It meant you needed to advocate for patients, even if it meant pushing your colleagues who were trained to relook, to revise their diagnosis, and sometimes, no matter how diplomatic you are or your intention, it is not well received. Resistance by colleagues to urgent requests to a deteriorating patient were now constantly attended to, or with appropriate urgency, which affected patient outcome, and at times made it near to impossible to deliver proper management. There was no clear understanding or appreciation, especially from management and administration, of the actual workload, even for a 6-bed facility. The question often posed to me at management meeting was that compared to a standard 50-ward bed ward in the hospital, how much work could a 6-bed ICU facility really need? But despite all that, we managed to achieve what we set out to do. Within 1 year, we managed to have progression in our workforce developments. We managed to change a lot of the existing predated systems to more efficient monitoring workflow systems. We developed a rapid response system that was now used nationally, not only within the hospital, but also in peripheral nursing stations. And it meant that the sickest patients were getting recognized through a quantifiable and justifiable way, and it empowered our nurses to advocate for their patients. And the patients were surviving their critical illness. The mortality rates dropped dramatically from 80% previously to 19% in the first year of the service. And we were able to maintain it below 20% for the last 4 years. Within 3 years, we had established an ICU team, a capability building training plan for the workforce, and an established system of operations. But we still only had the same number of registrars and the same number of nurses sustaining the roster since beginning. At the beginning of this year, we still only had 1 senior clinician, who is now me, and 2 junior registrars earmarked for Anaesthetics, because it was the only available program they could join. And fresh out of internship, and no further plan by management to get any more medical staff. So for health reasons, and for my own sanity, in view of an unsustainable and unsupported workforce, I left the service in April this year. And since then, ICU has reverted back to an open unit. So it comes as no surprise that the immediate rise in mortality rates over the following 3 months. Over the last 6 months, since leaving the service, I've been struggling with an overwhelming sense of guilt. What did we do wrong? What could we have done better? These are the questions that have plagued me since. Was there any point even in starting the service to begin with? And was it all a waste? And then I remember the patients we've helped since we started. The little neonate with persistent atrial tachyarrhythmia for the first 2 weeks of life that we cardioverted and sent home within a week. The little 2-year-old baby girl with severe sepsis and multi-organ dysfunction from a septic foot. She needed an amputation, but with support survived her illness and went home alive. She's 6 years old now. And I remember these patients who survived because we had an intensive care function at the time. The ones who had come in with no expectation to live, but defied all odds and walked out alive. I'm reassured that we did something right. I've always believed that the only person you can truly change is yourself, and people's decisions and choices will be their own. Samoa ICU did not fall apart because we did something wrong or did not do it right. It happened because of factors that were beyond our control, beyond what we could affect. And one day Samoa will realize its potential to do more than we've limited ourselves to. And when that day comes, we will certainly remember and give thanks for this man. I want to thank and acknowledge Dr. David Gallo, our mentor and good friend. Samoa has no idea how much you've done for it, but I thank you on its behalf, you and all the wonderful intensivists we've come to know. Thank you for all your hard work in developing ICU in Samoa, for teaching us that we did not need a whole lot of expensive equipment or high-tech resources to provide good quality care. We just needed to make the most of what we had. I have no regrets, and I would do it all over again, even if I knew it would happen exactly like it did in the end. Because without a doubt, those patients we helped survived because we had a service. I don't know what will happen in Samoa. It still breaks my heart to hear of patients with reversible conditions not surviving their admission. But I know Samoa has had a taste of it now, and it will happen again in the future. And for me, well, for now, I'm going to rest, get better, get stronger, and gear up. For now, I'm going to live to fight another day. Thank you.